without taking the patient onto ECMO, you treat that. But there are lots and lots of patients who are not on any antibiotics at all in UK when they are in ECMO. They are not an antibiotic. So antibiotics are not needed as a prophylaxis for the circuit as such. They can be off antibiotics. Think about your physiological region where you are and what your problems are locally, and try to modify it to your local concepts. Neurologically, they need frequent clinical assessment by looking at the pupils. As I said, we don't want to paralyze them usually, so they should start moving as well. That is quite important to keep an eye. In neonates, when as long as the head anterior fontanella is open, they need head ultrasound scans at least in alternate days. Okay, you know about this circuit diagram. Anticoagulation, if there is anything new, then I will mention, but otherwise Nanda has mentioned about that. This is the hemocrine mission which we use in United Kingdom. Heparin concentration, this is useful. How do you make up heparin? There are 3 standard infusions you can use for making up heparin. 5,000 units in 50 ml of 5% dextrose for patients with less than 10 kilos. 10,000 units in 50 ml for patients between 10 to 30 kilos, and 25,000 units in 50 ml 5% dextrose or normal saline for adolescents and adults, or those with more than 30 kilos. These are the 3 standard combinations available for making heparin infusion. With those infusions, you tend to run it on hourly basis to see how much heparin they need. Minimum bolus, when the ACT is quite low, we tend to give 0.5 ml bolus, then recheck the ACT. If the ACT is below the desired level, then increase the heparin infusion by 20% and recheck ACT every 15 minutes till back within the desired range. So in adults, we can give 1 ml bolus, then recheck the ACTs, and similarly you can increase the infusion rate by 20%, or if it is very high, you can reduce it by 20%, etc. Rest ventilation I talked about. Monitoring, when patients are in ECMO, 2 circulations exist: native circulation of the patient as well as the ECMO circuit. So monitoring should be done on both the parameters, clinical and laboratory. Though we have shown a lot of sophisticated gadgetry to use so far, they are all really not required for running a case of ECMO. What all you need is arterial blood gases or some sort of blood gases, daily bloods, hemoglobin, electrolytes, cultures as and when needed, a C-reactive protein, and activated clotting time. This is all is needed for running a patient on ECMO. The rest all, if you have them, well and good, but it doesn't mean that if you don't have them, you cannot run ECMO. It is not the situation. If you have a thromboelastogram, fantastic, but it is not a must to run ECMO. Monitoring, some patients on ECMO are dependent on stopping ECMO even for a few seconds also. So careful monitoring will prevent complications like clotting of oxygenator or circuit, blocked cannulae, raceway rupture, air embolism, and accidental decannulation. Be very, very mindful about accidental decannulation. In these days, when you are encouraging the patients to move, and we're doing lots and lots of chest physiotherapy, cannulae tend to migrate if we are not putting a lot of emphasis on it. So when you are doing daily X-rays, be very, very careful that your cannulae are staying in the same position. If the cannulae comes out, you will probably lose your patient. So you have to be extremely careful about accidental decannulation. Okay, clinical parameters I mentioned. In addition to that, as a luxury, if you have some cerebral saturation monitoring, near infrared spectroscopy will be quite useful, and that's what we do. Vascular status, urinary examination, as well as In case of femoral ECMO, please keep watching the calf muscles to avoid any compartment syndrome or any changes suggestive of ischemia of the lower limbs. Mean arterial pressure should be between 70 to 100 millimeters of mercury in adults, and in small children between 40 to 60 millimeters of mercury. But these are desired levels. If the patient is slightly low, and you cannot do anything, if you cannot do anything more to make it better, that is still acceptable as long as your metabolic components like lactate are okay. Dampening of the arterial waveform suggests malposition or cardiac stunning. In case of veno-arterial ECMO, it does recover as time goes by. The pre-pump pressures, we talked about it as well. In children, we tolerate up to -20, in adults up to -70. But if it is exceeding, commonest reason is low volume and we replace fluid. Poor catheter placement could be another reason, as well as inadequate cannula size. Pre-oxygenator pressures, they are helpful, but some of the circuits they can run, or ECMO can be done without that as well. The current practice does say we need to monitor pre-oxygenator and post-oxygenator pressures. Pre-oxygenator pressure is the pressure measured before oxygenator, as the name implies, that is after the pump and before the oxygenator. It increases with increase in the resistance. It depends on the type of the oxygenator and the surface area, blood flow rate, and the side of the arterial cannula. Systemic vascular resistance, if it increases, the pre-oxygenator pressure also will go up. Pressures are more in VA ECMO than in venous ECMO, and it can increase with kinking of the arterial side of the tubing. Clogging of the oxygenator will increase pre-oxygenator pressure as well. So it's a surrogate of that. Post-oxygenator pressure is measured after the oxygenator, as the name implies. It depends on the same as pre-oxygenator pressure and the cannula malposition and high occlusion by the roller pump. What is more important is the difference between pre-oxygenator and post-oxygenator pressure. If the pressure difference, the trend is changing, that is of lot of importance. That's called as delta pressure. It's a difference between the pre and post oxygenator pressure. It increases when the oxygenator starts clogging, and it also depends on the amount of blood flowing through the oxygenator. So the absolute values are less important, but it is a trend between pre and post oxygenator pressure that is important. Venous saturations are important. In veno-arterial ECMO, if you consider that, if you measure an arterial saturation in veno-arterial ECMO, it is more or less similar to the same amount of blood you are putting in back with the patient. So it doesn't give you a lot of important measures. What is important is measuring the mixed venous saturations or venous saturations. Venous saturations will tell you about how much oxygen is being used by the body. So that consumption is very important as a monetary measure in veno-arterial ECMO. In venous ECMO, arterial blood gases, they do hold good. So please mindful of that difference between the two. Even in veno-arterial ECMO, doing mixed venous saturations will help you in assessing how much blood is being used by the organs. Normal range is around 70%. This goes by like any other cardiac physiology. We expect the oxygen extraction to be around 25 to 30% in this. So factors affecting venous saturations are cellular or metabolic demands. If they are more, venous saturations could be low. The ability of hemoglobin to unload oxygen and the ability to deliver to tissues. So the causes for decreased levels are increased oxygen consumption and metabolic activity, tissue hypoperfusion. You can undo that by giving fluid, low cardiac output state, increase the ECMO flow rate when that is a problem. Sepsis or hypoxia, you can try to treat them. Causes of elevated venous saturations or when there is no extraction. In venous ECMO, there is more recirculation. That could be a reason. So check for the catheter position and reposition it. I'm sure you understand this concept of recirculation. So when blood is returned back from the arterial end of the cannulae, it will be going back into the venous end of the circuit without being utilized by the body. Clinically, you can recognize it, the color of the blood being closely the same in the venous limb as well as the arterial limb. Generally, you expect your venous blood to be blackish or darkish compared to the arterial blood, but when there is significant recirculation happening, then you see both the colors being the same. You have to separate the cannulae out slightly so there is more space for the blood to go into the circuit, as well as by reducing systemic vascular resistance also, you can help to reduce recirculation. Some amount of recirculation always happens, but we don't want it to be more. Recirculation is close to negligible in Avalon cannula, but at the moment they are not available in India. We have done few at KIMS on compassionate basis. We were given those cannula from US, but we are trying to make sure Avalon cannula become available in India and other southeastern countries. Dr. Joseph Schwanberger, he is the man who devised Avalon cannula. I am in continuous touch with him to make sure we people also will get Avalon cannula in future. Cerebral saturations are very important. There are a few slides here, but I just wanted to understand that. Have anybody used near-infrared spectroscopy? Yeah, good. So near-infrared spectroscopy gives us a valuable index of oxygen content of the tissue underneath those probes. If you put it over the scalp, it will tell you about cerebral saturations. If you keep it over the lungs, it will tell you the tissue content of the oxygen content of the lungs, and over the kidney region, it will tell you about somatic saturations or kidney saturations. So generally what we tend to do is we keep a couple of probes, one over the cerebrum or over scalp and another probe over kidneys. So we are measuring both somatic saturations as well as cerebral saturations. In general, you would expect your cerebral saturations to be 70% of the systemic saturations. That is the measure. So it's a non-invasive way of measuring oxygen saturation of the tissues underneath. Okay, it looks like this, as you have seen with this is the monitor and these are the probes over there, non-invasive probes. It works by injecting light photons into the overlying skin, which then scatter inside the scalp. By principle of reflectance, it returns and exits the skin, and we can read that with the photodiodes. Okay, and so there are two situations here on a couple of our patients who were on ECMO. Here you can see there was one patient with somatic saturations of 92 and cerebral saturations of 89. Are you happy with these numbers? Systemic saturations are okay, 92 acceptable, but cerebral saturations are high, 89. So there is no extraction taking place. Brain is not in a condition to extract oxygen. So it is a worry. In general, if you give time and maintain oxygenation for the next few hours, these numbers are going to get better. So just to make sure the same measures I told you earlier, managing the basal metabolic rate, minimizing the basal metabolic rate, with that it will come better. But it is a worry because brain may be in a temporary phase where the electrons or mitochondria are not in a phase to accept oxygenation at that time. It is a worry with the temporary paralysis of mitochondria, probably, presumably. But as time goes by, it gets better. The second situation is also worrying here because the somatic saturations are low and cerebral saturations are also low. So both the situations are worrying. It wouldn't be like that. Okay, so this shows here there is our scalp electrode here, and the photons, they are transmitted into nearly 2 to 3 centimeters into the tissue underneath the skull. Entitled CO2 is helpful. In neonates, it may not be very helpful when the tidal volumes are not great, and at times, our extremely bad patients are those with neonatal pertussis. You get 0 tidal volumes, no tidal volumes at all. Those are extremely poor patients. We did few few autopsies on them. Unfortunately, what it shows is it is a necrotizing bronchiolitis. That is the problem they are facing with in neonatal pertussis. So it is a dreadful condition. Fortunately, herd immunity in the country does protect our children. But if the herd immunity goes down and neonates get affected in the initial peripartum period, it tends to be very, very grave picture. So neonatal pertussis is something we are very, very much worried about. So following up the observations, the vaccination strategy has changed in United Kingdom. When we published this, now all adolescent girls during their pregnancy, they will have an acellular pertussis vaccination. So the vaccination policy has also been changed. If it is our problem as well, we need to think about issues like that. Okay, RPM, we dealt with that. Gas flow rate, ratio of 0.5 to 1 for washing of the carbon dioxide. Heart rate. Mild tachycardia can remain due to underlying diseases like sepsis, poor LV, contractility, etc. Pain and anxiety, one has to be very careful about that. So anxiolytics as well as analgesics, both have to be given to them. If severe tachycardia persists, then look for arrhythmias, high-grade fever, inadequate blood flow, or hypothyroid status. Temperature. Usually your ECMO patients do not show hyperthermia. The reason is on the ECMO thermostat, on the control, you indicate the time, you indicate the temperature at which you want the blood to go to the patient. If you indicate is normothermia, as it circulates through the patient, your patient will have normothermia despite the fact they have sepsis, despite the fact they are pyrexial, they tend to display normothermia. So be careful about that. Fever is not an indicator of sepsis when the patient is an ECMO. Neurological status, pupillary sizes. Sometimes when the ultrasound scans and CT scans, rarely when you suspect a gross neurological event, something like a cerebral hemorrhage has happened, in those cases you have to transport the patient to your radiology for getting a CT scan done while they are in ECMO as well. Okay, so like this leg ischemia can set in sometimes, so be very careful with that. It may be something to do with the distal perfusion of the limb. Urine output and color are important. Recirculation, we talked about it. So the take home message is pre-pump and delta pressure are important. They might indicate the coagulation status and the clots within the circuit. Mean arterial pulse pressure are important. Urine output and color. Venous blood gases. Some of the usual bloods we would like to have, and the circuit monitoring are important. ECMO monitoring is defined as hours and hours of boredom interspersed by moment of stock terror. Prevention is better than cure. You cannot expect to do ECMO without complications. They do happen, but with vigilance you can only minimize them.